Hello, dear students. We are here today to discuss the CBT test of Express PG. I am going to discuss about surgical questions and answers. I am Dr. Ajaysingh Chauhan. I am working as a consultant laparoscopic and colorectal surgeon in Pratap Hospital since last 15 years. I am going to discuss the surgical questions which are in your first exam. So let's begin with the first question. The first question asked is a 32-year-old male present with acute flank pain radiating to the groin. Urine analysis shows the following microscopic finding, which is shown in the image. The stone is radio opaque on X-ray. Question is, which of the following metabolic abnormalities is likely responsible for this condition? So you see the image and I will read the questions. First is hyperuricemia. Second is hypercalciuria with normal calcium. Third is urease positive bacterial infection, and fourth is cystinuria. If you see this image, you will directly get the answer. The answer is hypercalciuria with normal serum calcium. So you can easily give answer to this question because here the image shows envelope shaped crystals which are very characteristics of calcium oxalate, and these are the most common renal stones. Calcium oxalate crystals stones are radio opaque on X-ray and easily visualized on non-contrast CT. They are often associated with idiopathic hypercalciuria, lower urinary citrate, and ethylene glycol ingestion or high vitamin C intake. So we move on to second question. The second question is a 45 years old man present with epigastric pain that worsens after meals. There is no history of vomiting, blood, or weight loss. Endoscopy shows a chronic gastric ulcer. Which of the following is the most common site of chronic gastric ulcer? The options are lesser curvature of stomach near incisura angularis, B is greater curvature of stomach, C is cardia of stomach, and D is fundus of stomach. So if you see the options and if you know the anatomy, then you can answer this question very well. And the answer to this question is lesser curvature of stomach near incisura angularis. This question, for this question, you have to be very sure about the site of the most common site of the cancer or ulcers in stomach. There are two types of ulcer, benign and malignant, and the benign ulcers are most commonly located on lesser curvature, usually near incisura angularis, while the malignant ulcers are most commonly present on the greater curvatures. Pain after meal is typical of gastric ulcers, while dural ulcers in pain relief with food. We move on to third question. Our third question is a 60-year-old diabetic male present with intermittent claudication in his left leg. His brachiolic systolic pressure is 140 millimeter of mercury. His ankle systolic pressure is 70 millimeter of mercury. So the question is calculate the ABPI and interpret the result. So this is a quite mathematical question, but you have to be very sure about the calculations and we have to draw the conclusion and answer this question. First, we will see what is the correct answer. The correct answer is option A, that is 0.5 moderate arterial disease. The ABPI calculated is, we know that we have to calculate this with ankle systolic pressure divided by brachial systolic pressure, and that comes to be 0.5. So this indicates moderate peripheral arterial disease. We move on to the fourth question. Fourth question is a 25-year-old man present after crush injury to leg. His complaints of severe pain disproportionate to the injury and pain on passive stretching of his toes. The leg feels tense. The compartment pressure is 45 millimeter of mercury. What is the most appropriate next step in the management? As you can see, this question is regarding what you can see that compartment pressure is 45 millimeter of mercury means it is compartment syndrome, and you have to be very sure what is the immediate necessary treatment in compartment syndrome is immediate fasciotomy, and that is the correct answer. What is compartment syndrome? You all must have read it a lot of time, but still I will revise it for you. The compartment syndrome is there is increased pressure in the peripheral limbs causing vascular compromise of the hands or legs, foot. Here the pressure is more than 30 millimeter of mercury, which will cause ischemia of muscles and nerves. So fasciotomy is very important in this case to relieve the pressure and to relieve the compartment syndrome. Fasciotomy is decompression of the compartment by giving incision over the fascia and releasing of the pressure. What are the indications for fasciotomy? So these are compartment syndrome, crush injuries, reperfusion injury, snake bite, severe burns or tight cast, vascular injury following revascularization. And most common sites are legs, a forearm, and then hand, foot, thigh, and abdomen. So, what are the clinical signs for compartment syndrome? There are 6 P's: pain out of proportion, paresthesia, pallor, paralysis, pulselessness, and poikilothermia. So, the threshold pressure is 30 millimeter of mercury. Complication if we leave this patient untreated are Volkmann's ischemic contracture, muscle necrosis, nerve damage, and gangrene of the distal part, which will lead to amputation. We move on to the next question. Question number 5. You can see a diagram here. This diagram is showing Passaro's triangle. It is clearly shown. So this Passaro's triangle is between what you have to identify. There are vital organs like stomach, duodenum, gallbladder, cystic duct, common bile duct, and pancreas and pancreatic duct shown. So this the triangle drawn is Passaro's triangle. So we have to answer what is the other name for this. The other name for Passaro's triangle is gastrinoma triangle. Why it is gastrinoma triangle? Because see the boundaries of this triangle. Superiorly, there is junction of cystic duct and common bile duct. You can see it here. Inferiorly, there is second and third part of duodenum. This is second and third part of duodenum. And medially, that is head and neck of the pancreas. This is head and neck of the pancreas. So this triangle is called as Passaro's triangle or gastrinoma triangle. The tumor arising from this area, anatomical region secretes gastrin. So it is also called as Zollinger-Ellison syndrome because this is a neuroendocrine tumor producing gastrin, which causes Zollinger-Ellison syndrome. 90% of gastrinomas occur within this triangle. You have to know that percentage of the tumor occurring in this anatomical site also. And outside this have worse prognosis, which are especially in men type 1. So we move on to our sixth question. 32-year-old male is brought to the emergency department after being hit on the head during road traffic accident. On examination, eye opening, he doesn't open his eyes spontaneously but opens them when spoken to. Verbal response, he is confused, disoriented, and answering incorrectly but forming meaningful sentences. Motor response, when painful stimulus is applied, he withdraws his limb from the pain. So, what is his GCS score? This GCS score you have to calculate on the given questions. The correct answer here is answer B, that is E3, V4, M4. For this, you have to learn the GCS score very hardly, where you have to know which sign you are seeing and where is it E1, E2, E3, E4, E5 or V4 or what. So here what is given as eye opening is not spontaneous. So it's open on speech, that is E3. Verbal response is V4, that is he is confused but speaking meaningful sentences. And motor response is VM4, that is withdraws from pain. I will explain you GCS to some extent. If you could remember, just listen. Eye opening, what we give GCS score for eye opening, that is E4 is spontaneous opening, E3 is to eye opening to speech, E2 is eye opening to pain, and E1 is no eye opening. For verbal response, V5 is oriented patient, V4 is confused but speaking appropriate words, V3 is inappropriate words, V2 is incomprehensible sound, and V1 is none, no sound, not speaking. Motor response, M6 is obeys command, M5 is localizes pain, M4 is withdraws from pain, M3 is on giving pain, patient flexes the limb or decorticate, M2 is extend, that is decerebrate, and M1 is no movement. So you have to learn this GCS score very hard. Move on the next question. In question number 7, there is an instrument shown in the question diagram. You can see the instrument properly and you have to identify. The instrument shown in the diagram above is Cocker's forceps. So how do you identify Cocker's forceps? There are some identifying features of Cocker forceps. There is 1/2 teeth at the tip. You can see this tip. One tooth on the side and two on the other. There is ratchet and there is angle. So you have to see this and identify the forceps. Rest of the forces are different. Alice is having serrated tip instead of this 1/2 tooth. Babcock will have this kind of tip and Kelly's forceps is very sharp. This it will have this kind of tip. So you go see instrument or see the pictures of instrument and learn the characteristic features of the instrument. We move on to our next question, question number 8. A 68-year-old man with long-standing diabetes, peripheral vascular disease, and hypoalbuminemia undergoes emergency laparotomy for perforated terminal ileum secondary to ischemia. After resecting 25 cm of small bowel, the surgeon notes mild edema of both ends, mesenteric perfusion improved after warming, diameter mismatch between proximal and distal segments, high risk of postoperative leak due to comorbidities, contaminated peritoneal cavities, purulent peritonitis. The surgeon must choose the safest anastomotic technique. So you have to choose the safest technique. Which type of the bowel anastomosis is most appropriate in this situation to minimize risk, leak risk, and improve luminal patency? So there are four options: hand sewn end-to-end two-layer anastomosis, stapler side-to-side functional end-to-end anastomosis, hand sewn end-to-side single-layer anastomosis, stapled end-to-end anastomosis. So here the correct answer for this question is stapled side-to-side functional end-to-end anastomosis. So the explanation for this answer is that in high risk anastomosis scenario due to elderly patient, diabetes, peripheral vascular disease, hypoalbuminemia, contaminated abdominal cavity, mild bowel edema, luminal diameter mismatch, we have to think of the safest technique where we will have less anastomotic leak. And the safest option must provide us good blood supply, large anastomotic lumen, low tension, tolerance for diameter mismatch, minimal handling of edematous fluid, boil. So the best technique is stapler anastomosis. And why it is best? Because it creates a wide lumen, reducing stricture risk, handles diameter mismatch easily, stapler compressed tissue evenly, improving perfusion, safe in edematous and inflamed bowel. So these are the features of stapler, which reduces low leak rates and is considered gold standard in contaminated emergency bowel surgery. Why the other options are wrong? Hand sewn end to end two layer anastomosis, highest leak risk, not good for bowel edema, and two layer increases ischemia of ages. Hand sewn end to side single layer, better than option A, but still it is not ideal in ischemia or edema. Smaller lumen takes longer time in emergency setting, and stapled end to end requires diameter match, more tension, smaller lumen than side to side stapler, and increases risk in contaminated field. So hope you understood that answer. So we move on to the next question. A 48-year-old woman present with 2.5 centimeter lump in the upper outer quadrant of the right breast. FNAC confirms invasive ductal carcinoma. MRI shows no chest wall involvement. Axillary ultrasound shows one suspicious lymph node. PET-CT is negative for distant metastasis. Tumor is ERPR positive and HER2 negative. So which of the following is the best initial treatment option? Options are modified medical mastectomy, breast conservative surgery with sentinel lymph node biopsy, neoadjuvant chemotherapy followed by surgery, and radical mastectomy. So as per the new guideline, the answer for this question is breast conservative surgery with sentinel lymph node biopsy. In this patient, the tumor size is 2.5 centimeter and location is upper outer quadrant. And we are having FNAC sure of ductal carcinoma, no chest wall involvement, lymph node is N0, ER-PR positive and HER2 negative. So this means that this cancer is amenable to conservation. We can go for conserving the breast, and patient can have good cosmetic result along with clearance of the cancer tumor from her. with lymph node biopsy. And then we will further decide about post operative chemoradiotherapy. We move on to our 10th question. Which of the following diagram corresponds to Bismuth-Strasberg type E3 bile duct injury? So we have to be very sure with this answer. Four diagrams are shown: A, B, C, D. If you can see this diagram and if you know the answers, then it is very easy to answer this question. The answer for this question is answer A. You have to learn this classification of Bismuth Strasberg by heart. There is no other option than that. We move on to next question. Question 11. A 54-year-old man with liver cirrhosis due to hepatitis C undergoes screening ultrasound that reveals a suspicious liver lesion. MRI shows a single 3.5 centimeter enhancing mass in the segment 6 of the liver. There is no muscular invasion and no extra hepatic spread. Alpha fetoprotein level is 220 nanogram per ml. So, which of the following statement makes this patient eligible for liver transplantation under the Milan criteria? Option A is tumor is less than 5 centimeter, AFP is less than 100 nanogram per ml. Option B is tumor is single less than or equal to 5 centimeter with no muscular invasion. Option C is up to 3 tumors each less than 5 or equal to 5 centimeter regardless of vascular invasion, and any tumor less than or equal to 3 centimeter even with portal vein invasion. So the answer for this question is B, that is tumor is single less than or equal to 5 centimeter with no muscular invasion. So the Milan's criteria for this is single tumor less than or equal to 5 centimeter or up to 3 tumors and each is less than or equal to 3 centimeter with no vascular invasion, no extra hepatic spread. That's why the answer B is correct. That patient is having single lesion, that is 3.5 centimeter, no vascular invasion and no metastasis. This fits in Millen's criteria and transplant eligibility. We move on to the next question, that is 12th. Which suture technique is most commonly used to create the anastomosis in Ultimier's procedure? Ultimier's procedure is used for rectal prolapse, and the answer for this question is C, per string suture. It's very easy, but you have to be very sure about that. Per string sutures are used for Ultimier's procedure. In that, the prolapse rectum is pulled out, redundant rectosigmoid is resected, and coloanal anastomosis is created. The anastomosis is typically performed using per string suture, which allows circumferential approximation, helps to prevent anastomotic leak, and is ideal for low coloanal anastomosis done perineally. Sorry. We move on to 13. Question number 13. Best investigation for colodocolithiasis. So you have to be very sure that the gold standard investigation for colodocolithiasis is MRCP. You have to be very sure that is gold standard investigation, and there should be no confusion writing this answer. So we move on to our 14th question. The most common site for esophageal perforation, and you have to be very sure for this answer also. Left posterolateral distal esophagus. This is the most common most common anatomical site of esophagus for perforation. Question number 15. Most common tumor causing small bowel obstruction. This is a very rare tumor, but you have to be very sure. The answer is adenocarcinoma, while lymphoma, cyst and carcinoid are also the tumor, but they doesn't cause obstruction. This is very peculiar about adenocarcinomas of small bowel. See, we move on to question 16. See the diagram shown. There is reddish mass protruding through anal canal with concentric circular holes. What is the most appropriate definitive treatment for this condition in adult patient? I think you can see the mass coming and you can identify is it benign or malignant on this picture, and it definitely it's benign. So you have to tell what is the best management for this. This is rectal prolapse with redundant rectum, and the best treatment out of these four, that is sclerotherapy, rubber band ligation, abdominal rectopexy, conservative management with stool softener, and the best gold standard treatment is abdominal rectopexy. There are multiple treatment for rectal prolapse, but out of which this abdominal rectopexy is having less recurrent rate. The this abdominal rectopexy is less recurrent rate and better functional outcome in patients. But this is not correct for children. In children, we first do conservative treatment, and if not resolved with conservative, then only we move towards surgery. In adult high risk patient, we do perineal procedure first, that is Dillrom's procedure or Ultimaire procedure. This concentric folds, that is rectal folds, not prolapse hemorrhoids. So you have to be very sure about these fold, and you have to read this picture and keep it in mind. This pictorial description of rectal prolapse. This is not any tumor. We move to 17th question. There is an instrument shown in this question, and you have to identify this instrument. It is a drain. So which type of drain is open drain, gravity drain, closed suction drain, or capillary drain? If you have been into surgical ward, it's very easy to tell. If you have never been to ward or you don't have clinical knowledge, then you cannot tell that it is a closed suction drain. This is most commonly used nowadays, where we don't want to keep the drain open and leaking on the skin. So we use closed suction drain. It creates negative pressure and prevents the infection ascending inside. It is also called as Romovac suction drain or Jackson Pratt drain. So 18th question is a 62-year-old diabetic man present with fever and altered sensorium. He remains hypotensive with blood pressure of 78 by 46 mm of mercury despite adequate intravenous fluid resuscitation, and has warm extremities with raised serum lactate levels. So what is the most likely diagnosis? Option A is hypovolemic shock, option B is cardiogenic shock, option C is septic shock, and option D is obstructive shock. The given question itself tells the answer, and the answer is septic shock. In a diabetic patient with low BP and altered sensorium, the most common likely thing to happen is infection, systemic infection causing systemic septic shock. Persistent hypotension despite adequate fluid restriction in patient with infection is a diagnostic of septic shock. The presence of warm extremities suggests peripheral vasodilation, which is typically of early phase of septic shock. Raised serum lactate indicates hypoperfusion. Septic shock is a form of distributive shock caused by systemic inflammatory response in patient leading to vasodilation, capillary leak, and maldistribution of blood flow. Hypovolemic shock present with cold clammy extremities while cardiogenic shock patient will present with pump failure, and obstructive shock patient will have that from mechanical obstruction due to cardiac filling or output. We move on to 19th question. A 40-year-old man present to emergency department after stab injury to chest. He is hypotensive, tachycardic, and complains of severe breathlessness. On examination, jugular venous pressure is markedly raised. His heart sounds are muffled. Lungs are clear on auscultation. What is the most likely diagnosis? Option A is tension pneumothorax. Option B is acute myocardial infection. Option C is cardiac tamponade, and option D is massive hemothorax. The answer for this is cardiac tamponade. See, you have great clue that is lungs are clear on auscultation. So we can rule out the two, that is tension pneumothorax and massive hemothorax from the answers. The remaining two are acute myocardial infarction and cardiac tamponade. But being the history of stab, cardiac tamponade is likely. So we can have the answers very easily in such questions, cardiac and lung questions. Cardiac tamponade is caused by rapid accumulation of fluid or blood in pericardial sac, which leads to impaired ventricular filling, reduced cardiac output, and we have that Beck strides, hypotension, raised GVP, and muffled heart sounds. And while clear lung sounds, rule out the other tension pneumothorax or massive hemothorax. So the most common causes for cardiac tamponade are penetrating chest trauma, rupture of myocardium, malignancy, pericarditis, and the management for such patient is immediate pericardiocentesis. You have to do it in emergency ward itself. So we move on to our last question, 20th question. A 24-year-old man present after a road traffic accident with tachycardia and cold clammy extremities. His blood pressure is 100 by 70 millimeter of mercury. Pulse rate is 112 per minute. Capillary refill time is prolonged and urine output is reduced. There is no obvious external bleeding. He is conscious and oriented. So, what is the most appropriate initial management for this patient? Option A is immediate blood transfusion. Option B, rapid infusion of crystalloid. Option C, vasopressor support. And option D is emergency surgery. So, the answer for this question is rapid infusion of crystalloids. And you have to remember this thing, that in each and every patient of shock or hypotension with some accident, we have to infuse crystalloid as early as possible, secure IV line, and start giving infusion of crystalloids. The explanation for a hypovolemic shock is that how we diagnose hypovolemic shock is tachycardia, cold clammy extremities, borderline blood pressure, decreased urine output, and preserved consciousness. So the initial treatment we start with rapid volume replacement, that is crystalloids are the most preferred saline, that is RL or normal saline. And if patient doesn't have any improvement after giving crystalloids, then we give blood transfusion in severe shock or severe blood loss, or where we see ongoing blood loss. Vasopressors are not first line of management in hypovolemic shock. And surgery is only indicated if we see bleeding or any identified cause of shock in an unstable patient. So the answer is rapid infusion of crystalloids. So here we finish all the 20 questions in this paper. Thank you.